Tonight's webinar is very important because it's about a subject which touches literally everybody, mental health status of the professionals who are the building block of the next generation. The key speaker is Professor Dr. Mohammed Aziz Rahman. He will be introduced by the moderator. But before I introduce the moderator, allow me to introduce myself a little. I am Dr. Tuatwa Jeremiah Mtwarante. I'm the co-chair of the NCD working group, together with my colleague, Dr. Parajar Paikorol from Nepal. Me, I'm from Uganda. My background is definitely I'm a medical doctor, but with public health training. Currently, I'm the dean of the School of Health Sciences, Kampala University in Uganda. I've done many other things, but for purpose of time for this meeting, I will not go into that. My role tonight, first and foremost, is to introduce to you the subject matter, the topic for which I've already told you, fellow listeners, the audience, and my colleagues, the panelists. The moderator tonight is James McCune Amoah. His current role is the General Secretary of the Ghana Public Health Association in West Africa. He has previously been a national organizer and public relations officer of the association. His expertise lies in the field of project implementation in safe food environments, health policies, microbial stewardship, leadership, capacity building, quality improvement, and research, and non-communicable diseases. Professional background is a medical worker, is a registered nurse with over 10 years of experience. Currently, a senior nursing officer at the Renal Dialysis Unit, Kolebu Teaching Hospital, Accra, Ghana. Education background. He holds a Bachelor of Science in Nursing from the University of Ghana, a Master of Nursing Research from the University of Zululand, South Africa, and a Master of Science in Global Health, Liverpool School of Tropical Medicine. His research interest areas are in the tropical diseases, non-communicable diseases, health system strengthening, leadership, and safe food environment. So as you can see, he cuts across many areas in public health, is well-schooled, and I'm sure he's going to guide this discussion quite efficiently. I would like to urge everybody who is listening, all the audience, and all the colleagues out there to be attentive and listen tonight, because the subject matter is very important, as we shall see. So having made that, those remarks, please hand you over to the moderator, James McCune Amoah. Please take over to moderate this session.
Thank you very much, Dr. Jeremiah, for the introduction. Good afternoon, good morning, good evening to all of us for joining this important webinar. And I appreciate the time you are making to join this webinar. I'm hoping that by the end of this presentation, all of us will be well prepared to understand how post-COVID era will help ourselves in terms of our social issues and mental health, and how we'll be able to help improve upon our health and also the public health space. Our speaker for today is Dr. Mohammed Aziz Rahman. As you can see from the screen, I'm going to read his profile. This is just a brief profile of Professor Aziz Rahman, and he is an experienced public health physician and academic leader with over 20 years experience in public health research and teaching. He has expertise in research, funding acquisition, high quality publications, and supervision of high degree students. A special focus has been on tobacco control, non-communicable diseases, global health, mental health, indigenous health, and health promotion. With international experience, he's led many multi-country projects in over 20 countries. He developed postgraduate public health courses, established the discipline of public health in Fed Uni, actively supervises masters and doctorate students, known for supportive supervisory approach. His experience in Eltrob University, Duncan University, Australian Catholic University, and University of Adelaide. His community engagement has been mostly in multicultural communities and professional organizations as a volunteer, and he's also a member of the World Federation of Public Health NCD Working Group. Dr. Rahman, you can start your presentation now. Thank you very much.
Thank you very much, James. Thank you very much, Dr. Jeremiah. Really appreciate your introduction, and I'm really pleased and I'm really honored to get an opportunity to be here today and to share this topic. So today, what I'm going to share with you, as you have seen from the title of this, so I'm going to share this thing. The research that we conducted is a multi-country study that we conducted over 16 countries. And we have seen lots of mental health research, specifically during COVID-19 pandemic. The beauty of this thing that we have focused on a specific group of population which has not been examined so far. And during the COVID-19 pandemic, higher education institutions were greatly affected by different restrictions, specifically the changing pattern of the teaching, delivery, learning modalities, online deliveries, changing from face-to-face to online. So all of these things really impacted on the staff, even on the experienced staff, because they need to adapt this thing very quickly. And they faced dual challenges because they had this job insecurity due to financial crisis, as well as they had this physical and mental health issues. Those are really shared with the broader communities. Now, this ongoing global crisis of higher education institution has increased the likelihood of really prolonged psychological stress among all those staff. And therefore, we thought that we look at this specific group of population who have been teaching, who have been delivering the education and building the next generation of professionals, but what about their own psychological health? For any research, the first thing that we did, we tried to identify the gaps in evidence. So we tried to look at what is the evidence about the job insecurity, burnout, psychological distress, and coping among the staff who are working at higher education institutions. Unfortunately, we did not get enough evidence regarding all of these outcomes. Therefore, we decided that we will look at all of these 4 outcomes and we'll try to identify the factors which are associated with all of these outcomes. We also wanted to identify the extent of job insecurity, burnout, psychological distress, and coping. But at the same time, we also wanted to take this opportunity to identify whether they had the long COVID symptoms. We did this study last year. So we also wanted to understand about that COVID vaccination, what about their comorbidities, what about their behavioral risk factors. We also wanted to identify their healthcare seeking behavior. And we identified all of these issues, and we decided that we will look at this thing among all the university staff. When I said all the university staff, that doesn't mean the academic staff, because the professional staff, the admin staff who are behind the scene, they also contribute a lot, and they also go through the similar type of challenges during this COVID-19 pandemic period and the post-pandemic era. So we thought that we will focus on both administrative staff as well as the academic staff in our study. We did a cross-sectional anonymous online survey. We selected the higher education institutions who are definitely adults, who are staff, as I mentioned, so they are academic staff and professional staff. We developed a study questionnaire. It is a self-administered questionnaire, and then we developed the online survey link. We shared the QR code in different platforms. We shared this thing through emails, and we also displayed this thing at different university campuses, so staff would participate in this. We did not use any social media. We controlled the source population by distributing it through the emails and through different newsletters of each university settings who participated in this study. In terms of study tool, as I mentioned, so we use a structured survey questionnaire to identify and to measure all of these 4 outcomes. We have used these tools. Measure job insecurity, we use job insecurity scale, that is 4-item scale. To measure burnout, we use single item perceived measure, that is 1-item question. To measure psychological distress, we use Kessler psychological distress scale, that is 10 items. Most of you are quite familiar with this tool. To measure coping, we use brief resilient coping scale, that is 4-item scale. We started inviting our partner organization, and this partner organization came up based on my existing network. So we got 16 countries and more than 2,000 people who are working at different educational institutions, higher education institutions around the world. They participated in this study. If I just show you quickly about the countries which participated in our study, you can see these countries from Asia. You can, Australia also participated here. We got participants from South Africa, Mexico, and UK. In terms of study participants, we had 2,353 staff. Mean age was 43 years. 61% of them were female. Most of them were academic staff and working full-time. When we look at existing morbidities, it was very interesting to find that 1 in 5 reported they had not a single comorbidity, but multiple comorbidities. There was a combination of either hypertension, diabetes, heart disease, respiratory disease, cancer, and so on. Interestingly, 30% of the staff, they reported they had existing mental health issues. We also identified that 1 in 4 reported that they were ever a smoker, and 1 in 3 staff mentioned that they were drinking alcohol more than once a week. 25% of the staff who were current smokers, they mentioned they have increased their smoking habit over the last 6 months. And that number corresponds for alcohol. 15% of the staff say they have increased their alcohol intake over the last 6 months. Interestingly, 1 in 5 staff, they mentioned that they have not done any physical activities in the last 4 weeks. %66% of the staff reported they had experience of positive COVID tests. Interestingly, that's really good to see. 71% say they had triple vaccine, applying the triple vaccine. 1 in 3 participants mentioned that they are having the symptoms of long COVID. When we try to understand the health-seeking behavior and their own health status, interestingly, 8% of the staff mentioned that they never checked their blood pressure. 29% said they never checked their blood lipid. 21% said they never checked their blood sugar. And 17% of the staff mentioned they never visited to a healthcare provider for general health check. Now let's look at the main outcomes. What is the status of this? If you look at this, 15% of the staff mentioned they felt job insecurity. So that was really good that so many staff felt positive in the job. But 29% of the staff mentioned they faced burnout. 73% of the staff mentioned they have been suffering with moderate to very high psychological distress as we measured through the K10 scale. And 58% mentioned they had medium to high resilient coping. Now we also compared the prevalence among all those participating countries. I'm just sharing this thing, the lowest prevalence and the highest prevalence among all those countries. So in terms of job insecurity, the lowest prevalence was 6% in Turkey, and the highest prevalence was 27% in Australia. When you looked at burnout, Pakistan staff participated from Pakistan. They mentioned that burnout was 3%, whereas in Australia, the burnout was really high, about 41%. When you look at the psychological distress, the lowest prevalence was reported from Oman, and the highest prevalence was reported from Turkey. And finally, when you look at the high levels of coping, lowest prevalence was reported from Australia, 40%, and the highest prevalence was reported from Mexico, that was over 80%. Once we looked at all these countries, we also looked separately and exclusively for each individual countries. So I am from Melbourne, so we thought that, okay, I will look at Australian settings, and the other country collaborators, they are also looking at their data. They are still working on this. I'll just share quickly what we found in Australia. When we look at Australian settings with the data from Australia, job insecurity was 27%, burnout was 41%, moderate to high psychological, very high psychological distress was 72%, and medium to high resilient coping was 40%. So this was not that much different compared to the global study. Then I narrowed it down just to look at our university. When I looked at our university, if you look at the percentage, those also did not differ much compared to the Australian data and compared to the global data. So in summary, most of the staff face moderate to very high level of psychological distress. Almost 2/3 of the staff consistently reported moderate to very high psychological distress during this post-pandemic period. Now, if we look at a bit more details about the factors of the high-risk groups. So now I'd like to share with you who are the high-risk groups of people, what are the factors associated with those 4 outcomes. Let's look at the job insecurity. Levels of job insecurity was double among the staff who were working part-time, who were working in the research role, those who had multiple comorbidities, and those who had existing mental health issues. At the same time, we also found the levels of insecurity was double among the people who reported moderate to very high psychological distress and among the people who reported burnout. These levels of insecurity was tripled among the staff who had the academic appointment, who had the role of both teaching and research. Now, if you look at the burnout, levels of burnout was double among female, among the staff who had the leadership role, people who had any comorbidity, either single or multiple comorbidity, people who had job insecurity. And these levels of burnout was tripled among the people, among the staff who reported moderate to very high level of psychological distress. However, levels of burnout was 63% less among the staff who perceived their own mental health as good to excellent. Now, if you look at the psychological distress, levels of distress was double among the people, among the staff who had the admin role, among the staff who had existing comorbidities, who were ever a smoker, and who had failed job insecurity. And these levels of distress was tripled among the people who reported burnout and those who had existing mental health issues. Finally, if you look at coping, levels of coping was double among the staff who had academic and had the role of senior lecturer and professor, those who were a smoker, those who reported drinking alcohol, and the coping was tripled among the people who perceived their own mental health as good to excellent. Levels of coping was 25% less among the people who had the admin role and who had the leadership role, those who had comorbidities. And this coping was really 54% less among the staff who had existing mental health issues and the staff who had moderate to very high level of psychological distress. In conclusion, in this study, what we have done, we have identified the factors for all of these 4 outcomes: job insecurity, burnout, psychological distress, and coping among the staff who had been working at different higher education institutions around the world in 16 countries. What we need to do, the factors that we have identified, we need to consider those factors, and what we need to work on is to look at the existing support strategies at those higher education institutions. What about the support strategy for the staff to support their physical and mental well-being? And this is important that we review this and then we update and make necessary changes so that resources, those who are mission unable, staff know about this thing and then they utilize this thing in their need. We just got this paper published last month at the end of July, in fact. We published it in BMC Global, BMC Public Health. After this meeting ends, I'm happy to share the link if you are interested to know a bit more about this study. After we published this thing, it also attracted attention. So we got a newsletter article at Times Higher Education. Feel free to look at this thing. It's a snapshot of what we experienced there with the title of Burnout Looms. University staff continue to sacrifice own well-being for that of their students. I'm happy to share that link with you as well. And the last thing, it was also shared at the newsletter article of World Association for Sustainable Development, Health and Wellbeing of University staff who educated students and develop the next generation of professionals. Feel free to have a look at this. I'm happy to share that link as well. Finally, I would also like to acknowledge the organizations and all the collaborators who provided in-kind support for conducting this global study. You can see the name of all those organizations who participated in this study. I'm really grateful to all these collaborators, but at the same time, all the participants who donated their valuable time to participate in this study and giving us the opportunity to learn a bit more about their psychological well-being. With this, I would like to finish my talk. Feel free to be in touch with me if you have any question, or if you want to be connected with me, feel free to scan this QR code. You can connect with me through LinkedIn, and I'll be very happy to respond to any queries. Thank you.
Thank you very much, Prof. Aziz, for this presentation. Thank you very much. Is there any question for us? If you have a question, kindly write it in the chat and I'll read it to us. The first question is, will you receive e-certificate at the end of this webinar? That surely will be answered by Dr. Jeremiah at the due course. I can see there's a hand. Let me give the person the opportunity to talk. Please sing, you can unmute and speak. Thank you. So, Prof, there's one question. Is there a correlation with long COVID as a question?
That's a good question, Noella. Thank you very much for asking. Yes, we looked at the long COVID and we found strong association with some of these outcomes, but I have not presented this thing. Yes, that was also one of the contributing factor for having some of those psychological well-being.
So Aziz, my question to you is, how you see, the mental health status, because these days the public health professionals, the medical students, the professor, lecturers, they all are overburdened with a lot of work, So how you are visualizing, how are you seeing the mental health status of the professionals working in different countries? Is it worsening day by day, or what is happening in your point of view?
Thanks, Prajwal. So it is really, the issue is, we also need to remember that there is the issue of this challenge. It is really universal, irrespective of where you work, whether you work in Australia or whether you work in Nepal. The challenge, as I mentioned, so they have really taking lots of extra work post-pandemic situation, and this is really impacting on their physical and mental well-being. Apart from the living cost, that is also another issue that is contributing to this. The main message is, whenever they will have some of this distress, whether they are seeking help in appropriate time or not. Otherwise, there is an increased chance that that will go into really in the adverse scenario. As you have seen, people are having this high, moderate to very high psychological distress. So what we need to do from the organization point of view, they also need to give them enough support so they know that where to go, and then they can access this support. The other thing, based on this study and based on this finding, because there is a stigma attached to this thing. No one wants to label themselves that they are having some mental health issues. So we need to think of how they can access the support without being stigmatized. And one of the work that I'm conducting at this moment is really what is effective intervention to support them, whether it is a digital intervention so that they can interact, whether it is AI-based intervention so that they can seek help when they need. Because it is really important to look after this. And I was really surprised when I was writing this article. There has been very few, almost nil research that they focus on this important cohort of study. So to answer your question, it's important that the organization provides the support, but at the same time, the staff also needs to know, yes, there is support available. And then we need to think of how we can support them as a user-friendly manner so they can access this thing without any stigma.
Thank you, Aziz. My another question to you is, you to just talk about the artificial intelligence in mental health, So anything you want to highlight about what you are planning in artificial intelligence in mental health?
Thanks, Prajwal. So we have recently submitted a grant application where we plan that based on the information, it is not like this, it should be co-designed. So you need to involve the staff, what is really effective. Sometimes the challenge is, we as a researcher, we think that yes, it is going to be effective, but probably it is not going to be effective. So what we propose that, okay, we'll use the digital technology. The benefit of the digital technology, artificial intelligence, is you don't need to see, or you don't need to face a human being, rather than they can understand what's happening in your day-to-day life. So if they can access this thing through an app where artificial intelligence is integrated, so they can be referred to some of the support strategies. And that could be something that they can do this thing as a periodic manner. The other thing is, it is really important that we involve them in thinking what is really effective. And there has been less research on this thing, because what we develop, probably it is not effective in Australia, or it may be effective in Nepal. So we really need to think of their cohort, we need to think of their setting, and we also need to think of really what is the support policy. Sometimes we say, oh, you need to go and seek help, but probably this help is not there. If I mention from my personal point of view, I was born in Bangladesh. I know the mental health, there are lots of stigma there. There is no resources. If I compare this thing with Australia, there is a support service available. There is a phone call available. There is a support service like Beyond Blue. They can call, they can talk. But in Bangladesh, even they don't have that service, let alone having that service in the organization level. So really, it's important that within that limited resources, what is feasible, but it's also important to involve the staff when designing this, either this digital technology or it is an intervention based on the local context.
Thank you, Aziz. Thank you for the answer. Thank you very much.
Thank you.
Yes, I have a question for Dr. Aziz. If you look at the psychological distress, the levels are double among people who smoke. But if you also check the coping mechanisms as well, those who smoke have double coping. How do you relate to the two? Is it how does the smoking then lead to high psychological distress and at the same time coping for those individuals? Thank you.
Thanks, James. So, that as we have done this thing as a cross-sectional study, it is really difficult and challenging to start the temporal relationship. Whether the staff, they really started the smoking before they get depressed, or whether they get depressed and then they started having this smoking strategy. So really, we don't know the answer, which really started first. It could be they were distressed, and then to cope their situation, probably they have increased their smoking. Probably that is the possible explanation. Really, we don't know. We don't know really which started first.
Okay. There's a question by Noel that says, thank you. Also, how has this impacted quality of teaching or research or productivity, if at all, in the universities? Thank you.
That's a good question, Noella. So I really don't know. And probably it's a good research question to investigate further. Based on this thing, now we have the evidence. Yes, all this stuff had been going through this psychological distress. Now, how it is going to be impacted on the quality of teaching? And it is important to understand this thing. And if we can have this association about their psychological distress and the staff who are having this higher psychological distress, whether their quality of teaching is being impacted, probably that would be new and that would be good research to conduct in future. But I don't know this thing because we have not investigated this.
Thank you very much. The other question is, within loss of stigma, how can we bring champions in peer-led support for these individuals?
Well, that is the thing. That is our goal eventually. So someone will come forward and do this thing. So one of these things, what I have done, I'm not sure whether that will satisfy your question. In our organization, what we said that there is a well-being support team. So in that well-being support team, periodically they do different types of events. They invite people to come and join those, and they also do some periodic session where they say, oh, look, you need to go through this. And one of the common training that happens in Australia, that's called mental health first aid training. So that is mental health first aid training is really to support any staff in the acute situation. That is number one. Number two is the peer support that you have mentioned. That is really critical. So how staff will be involved in the peer support? The first thing is staff need to know that you are having some challenges, and then it needs to be shared. Now, whether the staff will share this thing or not, whether they have this privacy concern, there are lots of issues. Therefore, it is a big challenge to have this peer support until people know this. So one strategy could be if there is a peer support team and there is a confidential discussion, and organization can think of having a professional staff to support this thing, and there is no stigma attached. There is no professional, there is a confidentiality ensured in this conversation. I think that would be really helpful rather than having the peer, because really the staff will feel more comfortable to have a conversation with a psychologist or even a psychiatrist in a confidential manner, when they will also think that their job or their performance will not be impacted and it will be confidential.
Thank you very much, Prof. There isn't any question in the chat box. I think it means all questions have been answered.
Dr. Zormi has raised his hand.
Okay, Mr. Jeremiah, please go ahead.
Thank you. I would first of all, would like to thank you, the moderator, and of course, above all, to thank the professor for the excellent presentation. Now, I have about 3 areas which I would like to raise. One is that I want Professor Aziz to comment about this phenomena between the low and middle-income countries and the developed countries. How do we find the situation? Is it better in the developed countries compared to the low? Because we are witnessing a lot of healthcare workers fleeing the low and middle-income countries to developed countries. Number two,
I can answer to
That-
this question first, and Dr. Jagme, if that's okay, and then otherwise I will forget the question. So to answer this thing, really the challenges during the pandemic and the post-pandemic situation really differed between the definitely low, middle, and developed countries. If I mention the context, I'm in Australia, I can share what's happening in Australia. Sometimes people think, oh, you're in the developed country, we have all the resources, why there should be any challenge? The challenge in the academic sector, say for example, in Australia, during the pandemic, they closed the border, where UK, Canada, those developed countries, they opened up the border. They did not close the border. Now, Australian government decided that if they close the border, definitely they will contain the pandemic and all of this thing. And the border was closed more than a year. And what happened at that time, all the international students, that is a big market for all these universities in Australia, they lost all of these international students. And those students were diverted to UK and Canada. When they opened up the border in the post-pandemic situation, that return of the students still, after these 3 years, it has not even returned to that situation. And that impacted a lot in the university sector. And to recover the cost, the easy way is to have the job cut. And how to handle this thing? Because university needs to continue delivering the education with the domestic students because there was less international students. So what happened? The impact came on the staff. Now, this context is one of the disparities that you can see in UK, Canada, and Australia. UK and Canada probably was not impacted financially as Australia was impacted. Now, if you think of the low and middle income countries, as I mentioned, so probably they also face the similar challenge. And all of them really went from face-to-face delivery to online education. So it is a bit of challenge. And we can expect that probably the technology advancement was not that strong in those countries. So really the staff had to face this challenge in delivering the education. On top of this thing, in the low income countries, as I mentioned, when they had any mental health issues or the psychological impact, really there was no support service available. So really the situation was a bit complicated, and I will say a bit worse in those situations compared to the developed country where there is support service available.
Okay, thank you very much. My second question or concern, I would like you to comment about the impact of COVID among the healthcare workers compared to other professionals, like education, as far as this discussion is concerned.
Thanks, Dr. Jeremiah. So in terms of impact of the COVID, we also conducted another global study where we looked at this study focused on the university staff, but the other global study that we conducted during the peak of pandemic in 2020 and 2021 that involved 18 countries, we also published 10 to 12 papers from this. And we specifically looked at the healthcare providers, really what is their impact and all of this. If I can just share, in that study, definitely healthcare professionals, as you can see, they are the superheroes. They face a bit of more challenge. Their psychological distress was a bit more. And when you look specifically among the doctors and the nurses, so we also checked their psychological distress, their coping, their resilience. And again, there was disparities in terms of what we found. The situation and the service and the restriction, that was a bit different compared to developed and developing countries. So we had the mix of countries where some of the developed countries were participated, the situation and the COVID situation and the support in the hospital service was a bit different compared to the low and middle income countries, as we indicated earlier. So the situation was a bit different at that time. So we also looked at their psychological distress, but what I can say in that sense, they really had higher psychological distress compared to the general community people.
Okay, thank you. Lastly, of course, COVID-19 was a good learning lesson. Many countries came up with short-term solutions to some of these problems. Do you think we learned enough to really, for these countries, to put in place long-term solutions? Because the problem of healthcare workers is, to my understanding, is likely to continue if the long-term solution is not found.
True. Really, it was really the crisis management that happened during the pandemic, but it also gave us an important lesson that really, and I talked this thing in different forums. So that also showed if we don't address a problem in any part of the world, that will impact all of us. So it is really not any situation. So therefore, it is really important to improve the collaboration among all those countries to support one another, either, and I'm a researcher, so I will say from the research point of view, to extend that collaboration to really think of what is possible, and by collaboration, what we can do to solve some of those issues, so that when there will be any future crisis moment, so they don't battle this thing by alone. Thanks, Dr. Jamia.
Yeah.
Thank you very much for the answers. There isn't any other questions, so I presume this is the end of our webinar. Thank you very much, Prof. Aziz, for sharing your thoughts with us. And looking at the study you did, the countries that were involved cuts across all the continents. I know South America, South Africa, there's Europe, there is Asia, and looks like the findings that you have applied. So hopefully we will continue to see how best we could help provide the support you mentioned, so that we can get better coping mechanisms to be able to deal with our mental health issues. They are very real. One of the findings you mentioned was that women experience more burnout than men, which also means that the men must be ready to support the women in our lives, our wives, our sisters, our grandmothers, so that they don't keep experiencing more burnout and leading to other mental health challenges. So I want to say thank you to you for this presentation, and to thank all our attendees for attending this webinar. We'll come again with another exciting topic and we'll share with you. I'll hand over to Dr. Jeremiah, who is our co-chair, to give your concluding remarks, and we conclude this webinar. Dr. Jeremiah, over to you.
Thank you.
Thank you.
Thank you very much. First of all, the moderator for conducting this session quite well. I would like to join you to thank Professor Aziz for the wonderful presentation about this topic. As you know, mental health among the non-communicable diseases is one of those diseases which had been neglected for quite some time. It is only of recent that it is coming on board to be addressed. And I hope that most governments should take it up because it is bigger than we think it is. So that is there. Number two is that, of course, this lesson, the webinar is for us to discuss. And all of us who have listened to Professor and shall continue listening, the most important thing is what do we carry home after this listening? And in the end, how can we influence the people out there, particularly the policymakers, decision makers, to see to it that we can put in place the policies that provide a conducive environment to really handle mental health. So I would like to thank you very much, Professor Aziz, for the wonderful presentation, and we look forward to hosting you again, either on a similar topic or any other topic. We have started this webinar, NCD working group with various activities, and we would like to see to it that we create impact globally on this subject matter of non-communicable diseases. So thank you very much for the presentation.